I think we have to start because we have a huge topic to cover. This is the title. Hopefully, at the end of this presentation, we know much more about these terminologies. Time is brain, brain is life, act fast. Before I start my topic, a couple of housekeeping issues. One is, I was thinking about using medical terminology versus layman terminology. I decided to use both. Many times, your doctor, your provider explain to you radiology test results, ultrasound test results using medical terminology, and I think many of those terminology are already well known. But I try to use always the matching layman terminology. If you don't understand something, I use something which is strange, please feel free to interrupt me, and I try to clarify this. Regarding questions, hopefully you have many, or at least a couple. If the question can wait till the end of the presentation, probably this would be the best. But if it's very important, very critical, please feel free to interrupt me, and I try to answer the question if I can. Before we start this very nice, important and exciting topic, I want to just use some historical example. Probably you remember 20, 30, 40 years ago when cardiology started a big educational campaign about heart attack, what to do when you have a chest pain, don't stay at home, go to the ER. And I think they did a really good job. Nowadays, anybody who has any chest pain, chest tightness immediately goes to the emergency room for evaluation, and many times this very smart act can be life-saving. This is what we try to do with stroke. If you don't tell to cardiologists, I think that we try to follow their footsteps, right? Because they did a really good job. So let's start.
You clicked earlier, so
You
clicked earlier. Now you can do it.
All right. So what is the goal of this presentation? Try to understand at least the basics of stroke mechanism, recognize stroke risk factors, know stroke prevention measures, be aware of early stroke symptoms, and understand the benefit of early evaluation and treatment of stroke. A couple of stroke facts. Stroke kills almost 130,000 Americans each year. If you calculate this number per minute, one American dies from stroke in every 4 minutes. So during this presentation, unfortunately, probably 15, 20 our citizen colleagues will die from stroke. Every year, almost 800,000 people suffers from stroke. Stroke is a leading cause of long and serious disability. The estimated direct and indirect cost of stroke, almost $74 billion. This is data from 2010. Average lifetime personal burden, financial burden of the stroke, $140,000. Besides this financial burden, there is a significant life quality burden as well. Only 10% of stroke survivors recover completely back to normal without any leftover deficit. Another 25% of patients recover with minimal deficit. So if you combine these two numbers, roughly 35% of patients are able to continue the same life as they had before stroke. These are the good numbers. The bad numbers are 40% of patients experience moderate to severe impairments, meaning their quality of life significantly changed, not for better, for worse. 10% require even skilled care facility placement, and a good 15% die from the stroke. Still a couple of general issues. There is a difference between races regarding stroke risk. African American stroke risk roughly 1.5, 2.5 times more. Why is that? Likely because the higher prevalence of high blood pressure in between African American. Hispanic Americans having a higher risk as well, likely due to a higher prevalence of diabetes. Probably you have heard about the stroke belt. Stroke risk not evenly distributed in our country. Although the darkest purple states are in the highest risk, we are not the highest purple, but we shouldn't be very proud of ourselves, right? Our stroke rate is much higher than the average. Before I start to talk about different stroke mechanism, a very brief anatomy. Where the brain is getting the blood supply. Here is the heart somewhere, and there are two big blood vessel system which provides our brain with blood. Both are running in the neck. This is in the lateral part of the neck. You likely you have heard this is the carotid artery, big arteries on both sides, and arteries running at the back of the neck. These blood vessels are the major or practically only blood supplies to the brain. These two systems are talking to each other within the brain. It's very important because occlusion of one system, if it happens slowly, doesn't necessarily lead to problem if there is enough time to get the blood supply from the other side. That's why many times stroke presentation is different in different patients, depending how these two systems can talk to each other. We know brain is very important. This is what makes us human, right? Different brain areas are responsible for different body functions. Now we understand why different stroke patients have different symptoms. Depending on what brain area suffers from blood supply deprivation, oxygen deprivation, different symptoms occur. Very briefly, there are patients who have face, arm, leg weakness, if this brain area is involved, or sensory changes, if this brain area involved. There are stroke patients who cannot express themselves, cannot find the right words, with this brain area suffering from blood supply deprivation. There are patients who are not able to understand what we are talking, or patients who are losing vision, depending on which brain area is involved. What kind of major mechanism can lead to stroke? There are two big groups. One is called infarction, called ischemic stroke, when there is deprivation in blood supply and secondary oxygen supply. These represent roughly 85% of all of the stroke. The smaller group, when there is a bleed inside the brain. I try to briefly touch all of these topics just to have some basic understanding about stroke mechanism. Let's talk about first the ischemic stroke, when there is some blood supply problem. Majority of this ischemic stroke are due to called atherosclerotic pathology. What does it mean? It means that the big arteries, big blood vessels carrying blood to the brain are narrowing down or sometimes maybe completely occluded. It represents almost 60% of all of these strokes. There are a smaller group when deep, small blood vessels inside the brain are clogged. A very important group when there is a blood clot formation in the heart and some small piece is getting free, traveling in the blood vessel into the brain and blocks the artery. And there are other unusual cases. Let's talk about first this big group. I just mentioned this, right? What happens? There's a big artery. Let's assume this is a carotid artery. If there is damage in the inside wall of the artery, slowly some lipid cholesterol deposition starts, further calcium deposition starts, so this called plaque, probably have heard about this plaque, is getting bigger and bigger. There are two problems with this one. One problem is when they are getting really big, they narrow down the blood vessel, so it's much more difficult for the blood to go through this narrowed down blood vessel, and in certain situations the blood supply just not enough. So all of the blood, all of the brain area which is behind this blood vessel deprived from oxygen. There is another possible problem that sometimes some small piece of this plaque is getting free, travels in the blood supply, goes into the brain, and again blocks the artery and leads to stroke. This is when your doctor orders a carotid Doppler, carotid ultrasound, which can actually measure the size of the carotid arteries and gives a pretty good estimation about existence of plaque or non-existence, and if there is a plaque, how much narrowing does it cause. The other very frequently used technique is the MRA, which can check the arteries in the neck as well as in the brain. Now this is a very important table. One of the very first take-home message coming from here. What are the major cardiovascular risk factors? Untreated or poorly controlled high blood pressure. If somebody has this condition, the stroke risk can increase by 5-10 times. If somebody is smoking, stroke risk is increased doubled actually. Diabetes, doubled. Hyperlipidemia, high cholesterol, 1.5 times more. Obesity, and it's a relatively newly recognized independent cardiovascular risk factor, sleep apnea. Untreated, unrecognized, untreated sleep apnea can increase stroke risk up to 3 times. Unfortunately, if somebody has more than one risk factor, the risk of stroke significantly increases. Let's make some calculations, right? Let somebody smoking, has diabetes, 2 times 2 is 4, and has sleep apnea, 4 times 3, 12. Meaning, if somebody has these 3 risk factors, their risk to develop a stroke increased by 12. If somebody has all of these, let's make this calculation, it's a very scary number, right? 10 times 2, 20, 40, 60, times 3, 180 times the stroke risk. Now we understand how important it is to recognize these risk factors and to treat these risk factors. We like to practice evidence-based medicine. So these numbers are not just coming out from nowhere. These numbers came from epidemiologic studies or clinical trials. I just give a very brief overview. Let's see what happens with high blood pressure. This is, you see, this is a 60 months, 5 years follow-up. Patients who had high blood pressure and not treated, placebo means no treatment. In 5 years, more than 8 patients out of 100 will suffer from stroke. In the same severity of blood pressure, high blood pressure patients who are treated, so blood pressure is in a good range, in 5 years, roughly a little bit more than 4 strokes per 100 patients. So there is roughly 36% risk reduction, which is a very significant number. What are the goal blood pressures? It can change time to time. As today, this is a target. We don't like to have the blood pressure higher than this. Measuring blood pressure is a tricky issue. We think that it's easy. Yeah, it's easy, but sometimes it can be misleading. Going to the doctor's office, right, measuring blood pressure, even if the doctor doesn't have white coat, still, due to anxiety, the blood pressure can go up. So that's why it's very important to get some home measurements. Very easy to use devices are available, Walmart, CVS, any kind of drugstore. You can use, easy to use with one hand. And this is really informative about your usual everyday blood pressure. And especially it's important if somebody already have been diagnosed with high blood pressure and to measure the effectiveness of the treatment. How about smoke? As I told, I showed you, smoking can increase stroke risk. I'm not talking about heart attack and other risk, up to 2 times. In men and women, pretty much the same. Of course, it depends how much do you smoke and for how long. A very important take-home message. Hopefully you see this green line shows smokers' stroke risk. It's a 20 years follow-up. You see that after 20 years, the stroke-free population is around 73% or something. Non-smoker, 80 to 83% of patients are stroke-free after 20 years. The take-home message, if somebody was a smoker, stops smoking, after 3-4 years, the risk goes to the same level as for those patients who never smoked. So definitely, quit smoking is beneficial. Again, after a couple of years, the risk goes down to the same as non-smoker. Diabetes. Diabetes increases risk for stroke itself, but there are other issues. Diabetic patients can get stroke at much younger age. The stroke can be more severe, can lead to death much more frequently, and recovery from the stroke is less complete. Lipid lowering, cholesterol lowering drugs. Everybody knows statins, right? Different kind of statins. I don't want to tell names because I don't want to promote any of these because all of those are working. You see this number, reduce the stroke by 30%. And actually, it's not just, they are working not just through lowering cholesterol level, blood cholesterol level. But you remember, we talked about these plaques, which sometimes have tendency to break down and causing a problem in the brain. these medication, these statins, can make the plaque more stable. So much less likely that the plaque breaks down and causes some stroke in the brain. Everybody knows what is TIA, what you call mini stroke, right? Everybody, I had a mini stroke. TIA, I think it's pretty much known medical terminology. It's not really appropriate, the mini stroke, because it's not really a stroke. This is the whole meaning of this. It's more like it's a warning stroke. Patient has just transient blood supply problem, which pretty much subsides on its own without causing any brain damage, any cell loss. Usually it lasts for 5 to 10 minutes, but by definition, definitely all of the symptoms should subside within 24 hours. The problem is, again, warning stroke. The risk that patient after a mini stroke, a TIA, gets stroke is 10 times higher than in patient who never had this one. 35% of the patient who had TIA will have a stroke within 3 to 5 years unless a patient gets appropriate stroke prevention. Again, we discussed this brain already. What kind of symptoms patient can have from this kind of TIA or warning strokes? Weakness, unilateral, one-sided weakness, one-sided sensory loss. We discussed word-finding difficulties called aphasia, word-finding difficulties, visual loss on one side of the word, dysarthria or layman slurred or garbled speech. These are very serious symptoms. Let's go further. It can stroke or TI can present with bilateral weakness, bilateral sensory loss, diplopia or layman double vision, spinning feeling, vertigo, ataxia, balance difficulties, walking difficulties, dysphagia, meaning difficulty swallowing, coughing, choking on food. All of these symptoms can warn for TI or even an actual stroke. So what can we do with all of these risky things? We have to treat them. Unfortunately, we have to deal with this called non-modifiable risk factors. As today, we cannot do too much about it. What do I mean? Age. As we are getting older, unfortunately, stroke risk increases. So far, we cannot do too much about it. Gender, race. I already showed you a couple of issues why a certain race has higher risk. And genetics. What we got from our parents, this is what we have. But, and this is the whole purpose, one of the major goals of this meeting, right? To learn about what should we do with modifiable risk factors. The high blood pressure, treat high blood pressure. Lipids, we can treat lipids. Not just with diet, if somebody needs, with appropriate medication. Smoking, quit smoking, or don't even start. Diabetes, sleep apnea. If somebody has suspicious presentation, heavy snoring, stop breathing while sleeping, daytime sleepiness, definitely it's beneficial to evaluate patient for possible obstructive sleep apnea, and if it's the test confirmed, use the appropriate machine. Weight loss, physical activity. What general treatment do we have? The backbone of the treatment is called antiplatelets agent. The representative is the aspirin. I will show you some more. And makes some sense, right? If the big artery, a big plaque is building up, experts, vascular surgeons, vascular interventionists can clean that artery. So let's go with the antiplatelets. What kind of options do we have? The easiest, cheapest option is aspirin. I'm sure that many of you, most of you, some of you are taking aspirin on a daily basis. There were big clinical trials. What is the right dose of aspirin? Between a baby aspirin and 325 milligrams aspirin a day, probably both doses are working. More aspirin than 325 milligrams a day probably doesn't have extra benefit, it just has more side effects. Somebody who is aspirin allergic, not very frequent, but sometimes it happens. Plavix is another medication which can help as a general measure. And the third medication is called Agranox, which is a combination of aspirin and another drug. Unfortunately, none of these medication gives 100% protection. You see what is the stroke reduction. Okay? So aspirin itself is not enough. We have to deal and treat all of the other risk factors. The other issue, right, if the buildup is too big, we can clean the big artery, the carotids. Let's see what are the results, right? If there is big carotid artery plaques which causes more than 70% of narrowing of the artery and patient has some symptoms, they compare what happens if we don't do surgery, only medication, or we do surgery. You see the difference. Surgery works much, much better. If the stenosis, the narrowing of the artery, is less than 70%, likely the surgery is not better than just doing the right medical treatment. So this is the big group. Ischemic stroke, not enough blood supply going to the brain, and involves big arteries in the neck and in the brain. The smaller group, when arteries inside the brain, the small arteries, small blood vessels inside the brain are occluded. I mention this because likely you have heard about the terminology expression that patient has a lacunar infarct. It means it's a very small infarct, so it doesn't involve big part of the brain. On the CAT scan, maybe just a little hole here and there. Many times when we do a CAT scan, a head CAT scan for some other reason, patient fell down, we want to rule out injury, do a CAT scan, and the CAT scan comes back that patient has old lacunar stroke. Many times, patient doesn't even know about it. Okay, so this means that there is some small brain area which didn't get enough blood. Treatment, risk factor management, pretty much the same what we discussed just before. There is a very important group of strokes. This is called cardiogenic embolism. What does it mean? There is a blood clot formation in the heart, and because this is unstable, small pieces of this blood clot can get free, travels through the big arteries, going into the brain, and clogging arteries causing stroke. What are the conditions which can lead to this blood clot in the heart? The biggest group is atrial fibrillation, meaning irregular heart beat. It's a special irregularity. Big heart attack can cause this one, and other smaller group, which I don't want to go into detail. This is the major issue, atrial fibrillation. Right? This is the heart. There is a blood clot in the heart, which can break down and can cause the problem. Why it's so important? Atrial fibrillation is not so rare. You see, above age 64, more than 2 million people have atrial fibrillation. If patient has atrial fibrillation and not treated, it can lead to stroke, 35% during lifetime without treatment. Why this is a very hot topic? Because these numbers over here, right, 300 million versus 2 million is not really, it's high. But probably in reality this number is much higher, because we know more and more about called paroxysmal atrial fibrillation, meaning the irregular heart rate is not constant, continuous. It comes and goes. Sometimes patient doesn't even know about it. Sometimes there is some fun feeling, but if there is no EKG done during that time period, this brief episode can be missed. And many times when we see stroke patients, of course we look for risk factors. Patient has no blood pressure, high blood pressure, no diabetes, non-smoker, exercise. Everything is fine, and we don't know why did he get stroke. We put the patient on Holter monitor. You know what is Holter? Put the monitor, do everything at home, and the little device records your heart rate. And it turns out that patient has off and on brief episodes of irregular heartbeat. And actually, even a couple of minutes can be enough for blood clot formation. Okay, so this is a very hot topic. And I'm sure that if you see your doctor more and more, they offer this option and diagnostic tool. What to do with this one? This is when we use the blood thinners. The old blood thinner is the Coumadin, right? You know what is Coumadin. It's a very good drug, but very difficult to deal with it. Why? Because you have to have regular check how thin is your blood. If the blood is not thin enough, it doesn't give protection. If the blood is too thin, it can cause bleed. There are strict dietary restrictions, right? Certain foods, especially vegetables and greens, interfere with the effect of Coumadin. So it needs a discipline from the patient and from the physician to keep the Coumadin level, the INR level in the right range. There are newer blood thinners, I'm sure. If you watch TV, you cannot really avoid all of the commercials, right? Predisposes, Xarelto, Aliquis. You see happy people with atrial fibrillation in the middle of nowhere because now they can go, because you don't need to check the blood level for this. Very effective, very important treatment for atrial fibrillation. There are other unusual causes. I don't go through this one. I just mentioned a couple of issues. Partial rupture of the big arteries due to trauma. Here and there, we see patients coming back from amusement parks with some neck pain, some stroke-like symptoms, many times young people. And it turns out that the carotid artery just split, not completely, but enough to cause some blood circulation problems. Migraine. Migraine is a very usual condition, right? Migraine with aura, meaning when prior the headache, patient has some symptoms, usually visual symptoms or numbness here and there. in ladies who are taking birth control pill, and even I don't want to mention who are smokers. In this combination, they have very high risk for stroke, although they are young, right? So age itself doesn't protect you from stroke. Drug abuse. Unfortunately, here and there we always see young people coming for big strokes, with big strokes. Of course, no other risk factors, just they are positive for cocaine or heroin or both. So these were the major ideologies behind ischemic stroke. There is not enough blood supply to certain brain area. A smaller group is the hemorrhagic stroke, meaning bleeding. Very briefly, what kind of bleeds can we have in the brain? Subdural hematoma is, I don't call really a stroke, it's a traumatic, mostly it's a traumatic bleed in between the skull and the brain. It can be bad, it can be fatal, but it's not really that kind of stroke what we talk about. Bleed inside the brain. The major leading factor is untreated, uncontrolled high blood pressure or aneurysm rupture. How do they look like? This is a bleed, right? Needless to say, there is a huge damage. And if this bleed is growing, you can imagine, it pretty much destroys the left side of the brain, and as the pressure increases, starts to push the right side of the brain. So both sides of the brain is non-functional. This is a very serious condition. Many times it can lead to death. The other serious condition is subarachnoid hemorrhage, when the blood vessel and aneurysm ruptures, and actually the blood goes all over the brain. This is again a very serious condition. 1/3 of these patients never make the ER. They die on site. 1/3 will make the ER appropriate workup with serious significant deficit. 1/3 of the patient, if they make to the ER and the ER does the appropriate workup, meaning a CAT scan, if it's necessary a spinal tap, and diagnose patient with this patient won't survive, but a relatively smaller hemorrhage, they can do life-saving procedures, meaning to clog the aneurysm to prevent any further bleed. There are big mimickers. So not every stroke-like symptom is stroke. Sometimes patient has TIA, we talked about, right? It's not a stroke, but it's, the risk is very high that it will be a stroke. Seizure, certain type of seizure presentation, just syncope, low blood pressure or heart rate problem, drugs, toxins, high blood pressure, we talked about it. This is the ER physician's duty to differentiate between these etiologies and the actual stroke. So this is not your call. Oh, maybe it's not a stroke, maybe it was just a syncope. Now, what is the problem? Why we are not as good managing stroke or stroke patients as cardiologists? Because there are a couple of myths among us. Myth. Stroke is not preventable. Now we know very well that it's not true, right? We already discussed. If we verify stroke risk factors and we treat them, up to 80% of strokes are preventable. It would be a big mistake to ignore this fact. Next, stroke cannot be treated if somebody had an actual stroke. It's not true. 1 or 2 slides later, I will show you. What can we do for an acute stroke? Those treatments were not available a couple of years ago. Now it's available. Okay? So it's not true. Acute strokes can be treated. Only strikes the elderly. It can happen at any age. Happens in the heart, now we know. Stroke happens in the brain. Recovery ends after 6 months. It's not true either. There is called brain plasticity, meaning certain brain areas are able to take over functions from those brain areas which lost function. And this improvement can go much further than 6 months. We will talk about all of these rehabilitation options. So these are the myths, and now we know that these are not true. These are the true effects. What is a big misunderstanding about stroke? Even physicians, non-neurologists, for a long time looked at stroke as a static event. It happened, we cannot do anything, case closed. It's not true. Stroke is a dynamic event. What happens? There is a brain area over here. This is the black area. There is a brain area which completely deprived from blood supply. Blood supply equals oxygen supply. We know that brain is the most sensitive organ for oxygen deprivation. 3 to 5 minutes, it's enough for the brain cells to die. 3 to 5 minutes, it's a very short period of time. Unfortunately, if there is complete deprivation of blood supply, this brain area is dead. We cannot do too much about it. But there are surrounding brain areas when the brain still has blood supply, but it's not enough. Right? This called, if you want, you can remember, called penumbra, but it doesn't matter. What matters to understand. So this is the brain area what we are fighting for. If the help comes on time, we can decrease this brain area which is in danger to die down to this little small area. Needless to say, if somebody has this small stroke brain area, maybe without any symptoms, any deficit, it's a huge difference between these two pictures. So what can we do? Probably you have heard about the the magic drug is the TPA, right? Which stands for tissue plasminogen activator. This is a medication what we can give IV, usually we give IV, and it's a clot buster, meaning patient comes on time, and this is the major issue. We can give this treatment only within 3 hours from the first signs of the stroke. Okay? Now there are data that we can extend this up to 4.5 hours in certain cases. Let's just talk about 3 hours. So the first presentation of the stroke, the first sign when somebody cannot lift up the right arm, the clock is ticking, goes to the ED. We have very, very strict stroke protocol. Within 5 minutes we have the CAT scan, we have the labs, ER physician evaluates the patient, and we can give this blood or clot busting medication, which can break down that blood clot, open up the blood vessel, and can save this area, brain area. I told several times 3 hours. This is critical. This is one of the major issues today, to understand how important it is to seek medical attention in a right place. if we gave this medication because patient came on time, or even if the patient missed the 3-hour windows, / 4.5 hour, okay? We still can do a lot of things. Very important, appropriate blood pressure management, appropriate oxygenation, glucose, treat the diabetes, the high blood sugar, DVT prophylaxis, make sure that patient won't aspirate and leads to aspiration pneumonia, fluid status, prevent seizures. So there are a lot of very important steps to treat a stroke patient. We immediately contact physical therapy, occupational therapy, speech therapy, make sure that patient rehabilitation starts as soon as patient can do that. Make sure that we prevent any further problems such as aspiration, infection, pneumonia. Stroke can cause a lot of problems with life quality. I just mentioned a couple of those. Daily living, grooming, eating, skin problems, brain, a lot of cognitive and mood-related issues. What happens with a stroke patient? We start rehabilitation on site while patient is in the hospital. There are inpatient rehabilitation facility, outpatient therapy, outpatient physical therapy, occupational therapy, speech therapy, if it's necessary, long-term facility, community-based programs. Why it's so important? Because we discussed, right, that the recovery doesn't stop. With appropriate treatment, patient can regain significant function, even after 6 months, after 1 year. So why patients are not coming and seeking medical attention? They don't recognize symptoms. Hopefully, we learn something today, right? If some of those symptoms happens, you know that, wait a minute, it might be a stroke. Symptoms will go away. You know how many times patient has symptoms at 8 o'clock at night, went to bed, hoping that next morning everything will be fine, and things are not fine next morning. Denial. Even if I know that maybe it's a stroke, I have heard, but it's okay, everything will be okay. Think nothing can be done. So why should I go to the ER? I know, if I had a stroke, I had a stroke. It's not true. Depending on the nature of the stroke, the size of the stroke, the time window, we can do a lot for stroke patients. This is just for recapitulation. Please, please, be aware of stroke / heart attack risk factors. These are the major issues. If we control these risk factors, we can significantly decrease stroke and heart attack risk. Don't forget, these numbers should be multiplied with each other. Okay, I don't want to come up with all of the numbers. If somebody has all of these, it's almost for sure the patient has a stroke, will have a stroke sooner or later. Okay? TIA, atrial fibrillation, untreated. Okay? Everything is untreated. If everything is treated, they pretty much goes to zero. Okay? So, we already talked about what can happen with an acute stroke. If patient has symptoms started just 10 minutes ago, decide to go to the hospital, to the ER for immediate evaluation and hoping for the appropriate treatment, for the appropriate acute treatment, which is TPA, right? Only 2 to 8% of stroke patients receive TPA. Why is that? One problem is with the patients. They are not going to the hospital. The other problem is 64% of the hospital as today don't give TPA. They are not ready for this treatment. It's scary high numbers, right? And I probably can tell you, we are not in that 64%. Berkeley Medical Center is a certified primary stroke center. We are able to provide all of the treatment, including appropriate diagnostic workup, TPA treatment for patients who suitable for this treatment, and all of the follow-up diagnostic tests and treatment modalities. What is FAST? This is a very easy to remember acronym. Face, facial drooping, facial asymmetry, asymmetric smile. Arms, numbness, weakness. In parentheses, you can use leg as well, or you can replace arm. Speech, slurred speech, difficulty speaking or understanding, and T, time. If you have any of these, it's time to call 911 or go to the nearest stroke center. Fast. Call 911, go to the nearest stroke center. And we understand now what did I mean with this. Time is brain. Brain is life, and act fast. Okay? Thank you. If any question, I'm ready to